aerosolized medication, or I don't know what I think. Whatever chapter 3 is, that's what it says. Everybody getting one?
I guess there's a few people not here yet.
Yeah. Ebony. Okay. This is, I gave you yesterday, while you guys were taking the quiz, I gave you a handout on how to, I think it was compensated blood gases, or when you're trying to determine the compensatory factor. So I'm continuously giving you handouts to assist you. Some of you, which is up to you, some of you have been trying to go to other sites or whatever, and I told you, if not that my way is the only way, but if you go out there, it's going to be some things out there that's going to confuse you, and some of it maybe next year you'll be ready for, but you're not ready for now, and it will totally confuse you. But it's up to you, because I can't tell you how to learn. But I try to provide handouts, and I thought this is the handout that I had given you guys with the hydration equation formula on it, but apparently I didn't. So there it is. I do apologize. And this has some of the information on it that we're going through. Practice and Procedures, Module 1. Oxygenation is oxygenation. It doesn't matter what class is being taught in. Right? Yeah. All right. So I want to make sure everybody gets that. That's ya.
Oh, thank you.
Okay, now remember, when I give you a handout for blood gases, you need to put it with that notebook or however you're keeping it, because we may go over blood gases Monday through Thursday. And we're, in fact, we're going to do blood gases today, because I got to move along. We've got to get further. But I want to make sure everybody had that handout. Now this one, I don't know if I gave you, look in your notes with blood gases, and do you see this? Do you all see any of it? I don't know if it's this color. No. Okay, I didn't know. I said, I don't think I gave them this either. I have lots of stuff on blood gases that I don't have anything to do when I sit and make charts and graphs. So that's green. Not that that matters.
Okay. It's a what?
There should be some, it's enough going around. Okay. All right, let's take it to green. Take a look at the green handout. Okay? Is there any extras? Give Letitia one, please. Thank you.
Anybody need this punch?
Sure. Oh, cow. He's got it in his bag.
It's all of it.
Oh, thanks. Oh, it's yours?
You got both yours?
Yes.
I didn't know if you switched seats. I'm sorry.
Okay, some of this is after the fact, but it'll help you guys for some of you that are still uncertain. I'm on the green sheet. The pH. The hydrogen ion determines the function of the acidity or alkalinity, which is based in the blood and body. And there you go, you know that. Next is the hydrogen ion. The hydrogen ion determines the pH. Acids will give off hydrogen ions. Bases will accept more hydrogen ions. Increase in hydrogen ion is acid. Decrease in hydrogen ion is alkaline or base. Okay? PCO2. This value represents the partial pressure of carbon dioxide in the lungs. It reflects ventilation and is referred to as respiratory. Greater than 45 is respiratory acidosis. Less than 45 is respiratory alkalosis. The PO2, we'll come back to that, but you know that's 2%. The PaO2 is 2%, how oxygen is carried. Next is the SaO2. That's the 98%, and it's carried by hemoglobin, right? You know that. Okay, then the bicarb. This value represents the kidneys, and it's referred to as metabolic. Less than 22 is metabolic acidosis. Greater than 26 is metabolic alkalosis, right? And then base excess. This is an abbreviation, BE is an abbreviation for base excess. It's an index for kidney function. This value will always follow suit with the bicarb values, always. And it's -2 to +2. Less than -2 reflects metabolic acidosis. Greater than +2 reflects metabolic alkalosis. Any questions? You probably said this would have helped the first week, right?
Yes.
I thought I had given it to you during the orientation. I'm sorry, but I guess I didn't give it to you because I didn't want to overwhelm you. Okay? But now you know. All right, let's turn to page 2. Number 1, the pH is 7.35. Well, I'm not going to go through this. What I'll do is I'll let you guys read this. Take this home and read this. And then if you have any questions, but we've gotten past this. We really have gotten past this. But look at the hydration equation in the acid-base balance. CO2 in the lungs, gas in the lungs, plus water in the lungs. And we understand where that water comes from, right? From hydration, because in the nose is responsible for humidifying, right? But sometimes we don't inhale through our nose. We talk when we're eating or whatever, or we may have a cold and we can't get the air moisturized or humidified through the nose. So we will inhale air through our mouth. If we inhale air through our mouth, how does that gas get humidified?
Doesn't.
Oh, yes, it does. I beg to differ.
Saliva in her mouth?
Huh?
When the saliva
No,
or
at the
back?
point of the carina.
Oh, okay.
At the point of the carina. The carina is responsible once the air reaches the carina. If the nose has not been able to do its responsibility because we've inhaled or a deviated septum, the carina is responsible for moisturizing or humidifying the dry gas. And so when it does get to the lungs, it's 100% relative humidity, meaning that that gas is carrying, that oxygen is carrying as much humidity as it can. All right? And so this is the water in this problem. Yes, sir?
So the carina, is there actually like fluid setting in the carina a little bit?
It's not fluid, it's just a plethora of capillaries, and when the gas is past the capillaries, it picks up the moisture.
So it's like a little greenhouse sitting there, kind of?
It's like a what?
Like a little greenhouse sitting there then?
Yeah, greenhouse, white house, whatever color you want it to be. Yeah. However you visualize it, Doyle, that's the color it is. Yeah. All right. So the CO2 in the water, that's yours too. Here. Oh, okay. CO2 in the water, that's in the lungs. And then the circulating in the blood is carbonic acid, that H2CO3. I went through that. That's really the carbonic acid. When carbon dioxide is produced in the cells, it comes out of the cells in the form of carbonic acid. But we just refer to it as CO2. but it's carbonic acid. And carbonic acid is volatile, meaning it'll break up. It's not stable. And if it goes to the lungs, it changes forms into CO2, which is a gas. If it goes to the kidneys, it changes forms into bicarb, and then the free-floating hydrogen ion. Okay? And then now you know that the free-floating hydrogen ion is the same hydrogen ion that determines the pH, and the free-floating hydrogen ion floats across the cerebral spinal fluid and the brain barrier in the brain, right? And it responds, or rather the central chemoreceptors will respond to that amount of hydrogen. Make sense?
Mm-hmm.
All right, so there's the hydrogen ion equation. Now, right now, I'm not going to go over carbon dioxide transport because we haven't gone through oxygenation, but I'll get there. We'll get there. Let's look at page 3. Respiratory acid-base imbalances. Everybody with me? Mm-hmm. All right. Respiratory acidosis. When you have respiratory acidosis, you have an increased PCO2 and a decreased pH, yes?
Yes.
Mm-hmm.
And physiologically, that means the patient is retaining CO2 because they can't get it out. COPD patients have a difficult time exhaling. And if they have a difficult time exhaling, what do we exhale on exhalation?
CO2.
So they retain CO2. It stays within their blood. It stays within their lungs. And so therefore, we call that respiratory acidosis, or clinically, we can't see them do this, but based on a blood gas, when we see an elevated PCO2, we know they're hypoventilating. They're not adequately ventilating, right? Or for that matter, anybody. But the CO2 retainer has a problem because we know their central chemoreceptors have been knocked out, right? All right. Now, new terms. When you have, I'll put a blood gas. When you have this condition, we know that you've learned it as respiratory acidosis, and in this case, it's acute or uncompensated respiratory acidosis, right?
Mm-hmm.
All right. Either one you want to call it. Another term that we call it, and it's going to be imperative that you understand this, because the PCO2 reflects ventilation. Everybody with me? Mm-hmm. This term is also a synonymous term referred to as ventilatory failure. It's right here on the sheet. Ventilatory failure. So whether you see, I'll write them so you can start doing a word association. Whether you see hypoventilation, hypercapnia, hypercarbia, acute or uncompensated, either one, doesn't matter. And by the way, for a lot of you, compensated is not an I, it's an E. Respiratory acidosis. Or acute ventilatory failure. You spell, Kathy. Why do we call it ventilatory failure? Well, because we know the PCO2 reflects ventilation, and the lungs are not or unable to do what they're supposed to do. So all of these terms are synonymous. And oh yeah, one I didn't put on there. Let me put it on the top. This is a decrease in minute ventilation. And how do we get that? That's tidal volume times respiratory rate equals minute ventilation. And normal minute ventilation is somewhere between 4 to 8 liters per minute. So if a person has a decreased minute ventilation, more than likely they'll be hypoventilating, and if we get a blood gas, we'll see respiratory acidosis. Okay? And it's imperative that you learn these because you will have case studies. And your case studies will say that your patient is hypercapnic. You won't need a blood gas. Because if you know what hypercapnic means, you'll know how to take that term and you will understand that the pH is decreased and the PCO2 is elevated. Everybody understand what I'm saying? If you don't understand me, please ask questions.
Can you please repeat
Repeat what?
what you just said?
I not know what I just said. No, I'm just kidding. Okay. You may have a case study, and in the case study, it could use any of these terms. When I was explaining it, I said hypercapnic. Or you can have a case study, and it says the patient has a decreased minute ventilation. If a patient has a decreased minute ventilation, you have to know how to associate that with blood gas interpretation. So you need to understand if they have a decrease in minute ventilation, they're hypoventilating, and that means they're retaining CO2, and therefore they're in acute respiratory acidosis. You've got to know how to use these terms because this is the world of respiratory care. We understand any bag that someone comes out of, we are able to look at things 10 different ways. It's just not one way. And it really depends upon the author who's writing. Okay? Okay. So all these terms mean the same thing. Yes, ma'am?
The 4 to 8 liters per minute, that's a normal minute ventilation.
Yeah.
So if you have a decreased minute ventilation, you know that it's going to be below 4.
Or it could be a person's minute ventilation, let's say, is generally between 7 and 8 liters per minute, and now their minute ventilation has decreased to 4. Even though we call 4 normal, that's markedly decreased for them.
For them.
Mm-hmm.
So they would have decreased minute ventilation and all those other terms too.
Mm-hmm. They could be hypercapnic, hypercarbia, but my point is to confirm we need a blood gas. But using these terms, you don't. You just know if a patient is hypoventilating or if a patient is hypercapnic, they're in respiratory acidosis. Terry Desjardins, your cardiopulmonary A&P author, he doesn't use the terms uncompensated or whatever. He uses acute ventilatory failure, and you need to know what that means. In COPD, he doesn't say compensated respiratory acidosis. He says compensated ventilatory failure. And just last year, they began to ask these kind of questions on the board. I've been teaching it for 10 years, but they just start asking questions. Some of the graduates say, it was on there. And I said, good, you know it. They knew it. Yeah. And so it depends. So compensated respiratory acidosis is the same thing as chronic ventilatory failure. You just have to know what the terms mean, and you certainly can't tell a physician, I don't know what this is. You should be able to tell him what it is. So all of these mean the same thing, okay? And if you look at it, if a person is retaining CO2, they're hypoventilating. Hypercapnia means an elevated CO2. There it is. This means an elevated CO2. Interpret the blood gas. You can say acute respiratory acidosis or uncompensated respiratory, the same thing. Acute ventilatory failure. Ventilation is dealing with that CO2. And we say that it's failing because the lungs are not able to get rid of the CO2. So do you see the association? Yes, ma'am.
Is there a difference between acute and chronic?
Absolutely. Chronic, the pH within normal range.
Oh.
Absolutely, it's a big difference.
That's not, we wouldn't use that term for chronic for any of these terms, would we?
Well, if you wanted to,
Because you said chronic.
if we change this blood gas, that's chronic ventilatory failure. The patient is still hypoventilating. The patient is still hypercapnic. The patient is still hypercarbic. But now instead of acute or uncompensated, I would call this compensated respiratory acidosis, and I would call this chronic ventilatory failure based on that. See the difference? Please ask me questions, because by the looks of your faces, everybody's not getting it. Or maybe I'm misreading, misjudging this morning.
You said compensated respiratory acidosis?
Yes, it is. So this would be chronic ventilatory failure. Okay, back to the handout. Number 1, again with respiratory acidosis, it can be called ventilatory failure. What determines whether it's acute or chronic is the pH. Right? All right. Alveolar hypoventilation, that's this. Decreased minute ventilation, that's that. Hypercapnia, hypercarbia, here they are. All these are terms that are used for this blood gas interpretation. So my point is, if you have a blood gas, we're going to use the blood gas interpretation, but as a respiratory therapist, we don't necessarily need a blood gas interpretation to understand the acid-base state a patient is in. If you have a scenario and it says that the patient is hypercapnic, you know what that is. If I see something and it says my patient is acutely hypercapnic, I know that's acute respiratory or uncompensated respiratory acidosis. That's how we think. Street vernacular, that's how we roll. We got it. We understand it. This is our area of specialty. This is what we do. Some physicians, certainly pulmonologists, but not all physicians will understand blood gas interpretation like we do. Nurses certainly don't. And I'm not minimizing any healthcare field or physicians. I'm just saying this is what we do. This is our specialty. Make sense? All right. All right, I'll leave it up there. Now, I'm going to skip number 2 because we haven't gotten with hypoxia. That's what I want to do today. We got to move along. Number 3, respiratory alkalosis. Of course, it's the opposite of number 1, right?
Yes.
All right. So now a patient is blowing off too much CO2, so it's hyperventilation, or here I have blowing off excessive CO2. And then they have an increase in pH, yes?
Yes.
All right. This is also called alveolar hyperventilation. It's increased minute ventilation. Hypocapnia and hypocarbia. It's the exact opposite. So again, these are synonymous terms, right?
Yes.
And this is probably how you'll see your asthmatic come in. They're wheezing, they have bronchoconstrictions, and they'll probably be hyperventilating because they're trying to get air through those bronchospasms. Make sense? All right. Any questions with 1 or 3? It's what I've been saying, but now you got it on paper. All right.
Just a lot of words that mean the same thing.
It's a lot of words that mean the same thing. You're absolutely right. So my point is, we're learning blood gases, but you don't have to have numbers to understand the acid-base status a patient is in. A therapist does not need numbers. You don't need a number. Give me an association. Tell me something else. My patient came in, or you got a scenario, patient came in and the patient is chronically hypercapnic. You know that's compensated respiratory acidosis. That's our language. This is where we specialize. We are champions when it comes to acid-base balance. We are. This is what we do. Okay, this is where we specialize. And so as a second year, I don't even bother with blood gases anymore with them. Yeah, whatever. Anything I give them, they know. So when you become a second year student, this won't be a struggle for you. Not at all. Especially after 2 clinicals and intensive care unit. You'll get it. But you must know these terms because they're just beginning to test. I've been teaching this for about 10 years, but they're just beginning to test on ventilatory failure, chronic ventilatory failure or whatever. All right, any questions with 1 or 3? Okay, now let's go back to number 2 and tie it into practice and procedures. And Kathy is crossing wires, but that's okay because it's all the same thing. You learn in practice and procedures, or we're learning about oxygenation and the indications. And so you know now, and it's imperative that you understand, we know now, oxygen is carried 2 ways in the body, right? When we know that oxygen is carried 2 ways in the body, when we see a PaO2, we know that's the small amount, and it's 2%, and it reflects external respiration. And then we know oxyhemoglobin is 98%. But on a blood gas, that value, that's not written like that. This is a saturation. So when we look at a blood gas value, we're actually looking at oxyhemoglobin, but it doesn't say oxyhemoglobin. It says saturation of arterial oxygen. And you know that reflects that. And it's 98%, right? Mm-hmm. Okay. And we know this is internal. It reflects, it's not exactly, but it reflects internal respiration, how much oxygen is getting to the tissues. Any questions? All right. And yesterday, just to go off a little bit, I talked about VQ mismatches. VQ mismatches is dealing with external respiration only. Gas exchange at the alveolar capillary bed membrane, something happened because of lung disease or something going on, and that gas exchange was not equal. Okay. When we make an agreement, you're going to do something and I'm going to do something, it's agreed, and you do your part and I do my part, and we're synergistic and we're equal, right? Yeah. Mm-hmm. Well, when external respiration is not equal because something has happened, like the lungs collapsing or whatever, when I talked about low VQ, I didn't tell you low or high yet, but VQ mismatches, and I talked about shunts, this is the 2%. This is hypoxemia. This is not enough oxygen in the arterial blood. And if we can catch it, it's okay because we know 98% is carried this way. But if we don't catch this, and when I say we, I don't mean us individually, but if the patient doesn't come in or diagnosis or whatever is causing this abnormality, if it's not caught soon enough, eventually it's going to affect this. But in most cases, except one of the hypoxemias, this happens first. Hypoxemia occurs first, then tissue hypoxia will occur second, in most times.
So VQ mismatch is the prelude to hypoxemia?
It could, yeah, it could be, yes. Mm-hmm. Or if you do have a VQ I don't even want to say it's a prelude. If there is a VQ mismatch, there is hypoxemia. Let's put it that way. Yeah. Okay, so we know the PaO2 8200, that's on room air, and we know the saturation is 93 to 97%, right? All right. Now I just want to tie something in for you. You say, okay, well, if oxygen is carried 98% and we know saturation is 93 to 97%, everybody with me? How come it's not 100? Because we have a normal physiological shunt in our body. Did you all know that?
No.
Yeah, we have normal physiological shunt. There are some veins in our body, and I don't want to go through them right now, but they're in the lungs. There are some veins that never dump the blood into the right side of the heart. These veins automatically dump venous blood, it's a small amount, automatically dump venous blood into the left side of the heart. So that's why saturation 93 to 97% is normal. Even with room air, we're okay. It doesn't matter whether your stat is 93, 95, 97, we're fine. Because we have a normal anatomical shunt. And a shunt means what? Venous blood being dumped in the left side of the heart. And what kind of blood does the left side of the heart carry? Oxygenated blood. So that's why our SAT is never 100%. The only time you'll see a SAT 100% is we know that a patient is receiving supplemental oxygen. Because we, as healthy individuals, have a anatomical shunt. Somewhere between, what, 3 and 7%. So that's why our saturation is not 100%. Does that make sense to everybody? I was waiting for somebody to ask me, but nobody asked. Any questions? So we have normal anatomical shunt. Cool beans. We're healthy. Some of our pulmonary veins dump right into the left side of the heart. Yes.
Okay, I was wondering if maybe it was like the veins that supply and work with the heart itself. Maybe
No, not coronary. No, these are Fabizian veins in the lungs.
The temper the
Veins,
blood,
rather.
you said they don't know why it does that?
It doesn't matter. It's normal.
But they don't have a clue as to why.
Doesn't matter. We're healthy. If it's not broke, don't fix it. Yes.
Like, isn't there more lymph nodes on the left?
Lymph nodes don't have anything to do with acid-base balance or oxygenation. Lymph nodes have to carry infection away to the bloodstream so that it can go to the kidneys or the liver and be metabolized. Lymph nodes are part of your immuno system. Okay? All right, so everybody understand now why we don't have 100% saturation. It's 93 to 97. Why? We have an anatomical shunt. And your text would tell you ideally it's about a 5% shunt. So if you look 93 to 97, what's right in the middle? 95%. So if we have 95% saturation and there's your 5% shunt, that equals 100%. Does that make sense? But for one individual, it could be 3%. For another, it could be 7%. Who cares? You're healthy. If no one told you, wouldn't even know it. But my point is, this is why saturation is never 100%. The only time you're going to see an individual saturation 100% is when they're on supplemental oxygen. Make sense? All right, any questions with that? All right, so we have a normal anatomical shunt. But now when it goes beyond that normal anatomical shunt, then it becomes a VQ mismatch. Got it? Thank you. And so you may have an individual, you may have a med student or a resident ask you, why isn't our saturation on room air 100%? You can tell them, because we have an anatomical shunt. And what's a shunt? You can tell them, right? A shunt is simply venous blood full of CO2 being dumped into the left side of the heart, which we know is primarily full of oxygenated blood. Make sense?
Yes.
All right, back to oxygenation. So what I'm going to do now, gonna stick with this respiratory gas. Okay, this is generally how you'll see blood gases written in this order. Now, we've done acid-base balance. You're still learning. I realize that. But now I've got a PaO2 in it. Okay? You're still going to go line by line. Don't ever try to just look at a blood gas and call it something. I don't do that. You need to go line by line because you can miss the mark. And missing the mark means that you could not intentionally, but because you made a mistake in the interpretation, it may have a deleterious effect on what therapy or whatever may be done for the patient. So just take your time and go line by line. So we know that's acid. We know this is acid. Now, PaO2 is 63. Normal is 80 to 100. It's decreased. Bicarb, well, no, I didn't write the saturation on there. Wow, I wrote so big. Okay. I'll just put the saturation up here, but on your paper, write it under the base excess. Okay. And I'm going to say, that is 93% is normal. All right. Bicarb is normal. Base excess is normal. And SAT is pretty good. So what I see is uncompensated respiratory acidosis, right?
Yes.
Okay. I could also call it acute hypercapnia. Would you agree?
Yes.
Everybody see acute hypercapnia? Does everybody see that?
Yeah.
Use the word association. So it's uncompensated respiratory acidosis. It's acute respiratory acidosis. I can call it acute hypercapnia. I can also call this acute ventilatory failure. Can I not?
Yes, you can.
Yes, I can. Okay. Now, I took care of the acid-base status. Now I have to address the oxygenation status because that's something different. So any of those terms that we use, you then have to say with hypoxemia. So if you go back to the basis, uncompensated respiratory acidosis with hypoxemia. And if you don't include the hypoxemia, it's wrong.
That's because there's a decrease.
It's less than 80. So with hypoxemia, you can call it acute hypercapnia with hypoxemia. Everybody see that? I can call it decreased minute ventilation with hypoxemia. I can use any of those terms, but I have to address this hypoxemia. And how do I know it's hypoxemia? Because it's the PO2. That reflects external respiration, right? Not enough oxygen in the blood. But I'm looking at my SAT, and my SAT is normal. So there is no tissue hypoxia. We've caught it, but it is hypoxemia. Everybody see that? All right. Any questions?
You know, just to make sure, I was writing when you said that
That's
very
good.
last part. Did you say that we caught it in time because we know it does not have, this patient does not have hypoxemia because of the saturation level still being at 93%?
No, the patient does have hypoxemia. The patient doesn't have tissue hypoxia.
Got it. Okay.
Yeah. This is tissue hypoxia.
Okay.
So would we,
That reading tells me. Okay.
so if it was below 93, would we write acute respiratory acidosis with hypoxemia and?
Now you would just write with hypoxia.
Okay.
Hypoxia.
Okay. That would help me because
Okay, so when you interpret a blood gas, you have to address the acid-base balance and determine whether it's acute or chronic or uncompensated, compensated, whatever one terms you want to use. I'm okay with that, whichever terms you want to use. That addresses the acid-base balance, but then we have to look at the oxygenation status. And you can never forget the oxygenation status. You can't overlook it. Okay? I can call this blood gas acute ventilatory failure. Can I not?
Yeah.
With hypoxemia. Yes.
Will you see acute ventilatory failure with tissue hypoxemia?
Yeah. Yeah. I just, in this particular
know.
blood gas, I didn't put it, yeah. You're going to see all kind of stuff, yeah. So, yeah. You can see this. Yep. It's still acute, what? Respiratory acidosis, uncompensated respiratory acidosis, acute ventilatory failure, tissue hypoxia. Yeah. That doesn't change the acid-base balance, yeah. You can just see this is hypoxemia and this is tissue hypoxia.
Yeah.
And here, now that we've changed it, you know peripheral chemoreceptors have kicked in. Because his PO2 is less than 60. And so first thing I expect to see with my patient, they're going to have increased heart rate. Next thing I expect to see, they're going to have an increased respiratory rate, probably, maybe, using some accessory muscles. I won't see it, but I know there's going to be pulmonary vasoconstriction. And then if they've been bad enough, if this has been going on bad enough, hopefully not, you're going to see them break out in a sweat. And their skin will be cold and clammy to touch. And if it gets bad enough, probably not bad enough, what happens as that oxygen declines, patients get disoriented and confused. When they start experiencing tissue hypoxia, they'll get disoriented and confused. They get real edgy and get real nervous, and they'll start pulling out things they shouldn't, like IVs, and holding and filling the cover because their brain is being deprived of oxygen.
Mm. That's when the saturation is low?
No, it can be that. It could be a PO2 of 33. Normal is 80 to 100, and they have a PO2 of 33. They're just not going to sit there. They're going to start getting disoriented. They're going to begin, their level of consciousness is going to be altered because oxygen is not getting to the brain. That's the whole concept of CPR. It's not to get the heart pumping. It's to get oxygen to the brain because the brain cells die. Okay, now I want to take this a little further. Let's leave it just like it is. We call it uncompensated respiratory acidosis with hypoxemia. We're just going to leave the tissue hypoxia out for now. If you just call it hypoxemia, it's good, okay? You can call it acute hypercapnia with hypoxemia, whatever those synonymous terms you are, as long as I know that you're using the terms correctly. Now let's go back to this ventilatory failure. I'm going to put another blood gas up here. I'm going to put the same blood gas, in fact. And what was the first stat? 93%?
Yes.
Yes.
Well, leave it there. I just want to leave it for the blood gas to be the same. Okay, look at the difference between these blood gases. The difference is this. Right? The acid-base status is the same. It's uncompensated respiratory acidosis, acute respiratory acidosis, whatever. And this is ventilatory failure, yes?
Yes.
However, there's no problem with oxygenation. So this one, we're just going to call it ventilatory failure and leave it at that. That's what it is. And so if the oxygenation status is normal, we don't have to say normal oxygenation. That's why it's important if it is not normal to mention it. Because if you just say ventilatory failure, I'm going to automatically know, well, it's nothing wrong with oxygenation. Make sense? But then if you say ventilatory failure with hypoxemia, okay, I got that too. See the difference?
Yes.
All right. Now, let's take this. I'm taking this. We're going somewhere with this. This is acute hypercapnia with hypoxemia, uncompensated respiratory acidosis with hypoxemia, acute ventilatory failure with hypoxemia, right?
Yes.
Yes.
Okay. This is Kathy Miller's 50-60 rule, right? 50-60 rule. 50-60 rule. I'll write it over here. 50-60 rule. When the PaCO2 is greater than 50, you know that's respiratory acidosis, yes? Yes. All right. PO2 of 60, you know that's when the peripheral chemoreceptors kick in, yes? This is PaO2. You know this is when peripheral chemoreceptors kick in, yes? Okay. Now, let's look at this first blood gas. This is bad. This is blood gas too, and it's bad because they're in respiratory acidosis, but they're oxygenating okay. Make sense? Everybody with me?
Yes.
You need to stop writing and listen. Okay, well, you can get back to that. This is not good, but at least they're oxygenating fine, right? But if we don't do something for them, whatever the cause may be, next time we indeed may have this, right? Because the more CO2 they retain in the lungs, the less oxygen they can take in, because the carbon dioxide is occupying the space where the oxygen should be coming in. Does that make sense? Okay. So here we have ventilatory failure. Here we have ventilatory failure with hypoxemia. What do we do on inspiration? Inhale what?
Air.
What kind of air? Specifically, what kind of air?
Oxygen.
Oxygen. We're inhale oxygen on inspiration. Not doing a good job of it, are we?
No.
The blood gas is. Then what do we do on expiration? Exhale CO2. Not doing a very good job, is it? Because this patient is retaining CO2, right?
Right.
Okay, back to my 50-60 rule. When you have a PCO2 greater than 50, what you do here, and you have a PO2 less than 60, what you do there, right? This is called respiratory failure. Write it down. Respiratory failure. Meaning the lungs are getting ready to shut down. The patient is inadequately ventilating, and the patient is inadequately oxygenating. So I've given you this uncompensated respiratory acidosis with hypoxemia, acute ventilatory failure with hypoxemia, acute hypercapnia with hypoxemia. All of those are correct. But when you see, in general, the 50-60 rule, and you have to know what 50 is, that's a PCO2 greater than 50, 50 or greater, and a PO2 60 or less. Ventilation is lousy, not so good. Oxygenation is lousy, not so good. The lungs are failing. We call it respiratory failure. This is acute respiratory failure. And some patients will have that diagnosis, respiratory failure. Therapists, we know what that means. Now, I'm not talking about etiology, because it could be whatever reason for it, but this is also called acute respiratory failure. And respiratory failure can be a diagnosis. A pulmonologist will use that. A thoracic surgeon will use those terms. And so we know what that means based on the 50-60 rule. Now, you're not going to find this 50-60 rule in the book. This is Kathy Miller. So if I ask you to give me a blood gas depicting or demonstrating acute respiratory failure, you need to be able to do that. Or I say, which of the following blood gases demonstrates respiratory failure? Of 3-4 blood gases that I give you, you need to be able to identify which one is respiratory failure. Now, this is not respiratory failure. This is ventilatory failure, acute ventilatory failure, because this PO2 is normal. There is a difference. Respiratory failure is the 50-60 rule. This is PCO2, this is PaO2. Yes, sir.
But that vent failure will turn into that eventually, right?
Yeah, eventually, yeah. Now, ventilation is one entity, oxygenation is another, yes? We ventilate, we know we breathe based off of CO2 drive. But if the lungs are retaining CO2, when the patient tries to inhale the oxygen, the CO2 is occupying the space where the oxygen should be. So then the oxygen can't get in, and then the oxygen values begin to decrease. Does that make sense? Okay. So we look at ventilation as one entity, and we look at oxygenation as another. But if a patient inadequately ventilates, eventually they'll inadequately oxygenate. So of the two, this is better. It's not raising a whole lot of sand, but it's better. And if we don't intervene, if we don't do something, then we're going to see this. And this is worse because they're not ventilating, they're hypoventilating, and then they have hypoxemia. And the peripheral chemoreceptors have kicked in. And we're seeing these clinical manifestations. We're seeing them confused. We see that they've broken out in the sweat. We see their heart rate is elevated. We're going to obviously see this. We're going to see it based on the blood gas. And so this term respiratory failure, you don't need a blood gas to see it. It could be a patient's diagnosis, and a therapist knows what that means. Now, I may not know where this stuff is, but I know the PCO2 is high and the PO2 is low. They probably need to be intubated on mechanical ventilation to correct the problem, because they're not ventilating and they're not oxygenating. And then what's going to happen, the tissues are going to be deprived. The brain will die. Any questions with this? Yes, ma'am.
Could we, I know you're talking about the word association, could we also call it acute respiratory acidosis with hypoxemia?
You sure can.
Okay, good.
Yeah,
Thank
you can interpret it like that.
Okay.
But like I said, you'll have patients that have the diagnosis of respiratory failure. You won't have to see a blood gas to know what that means.
Okay, thank you.
Mm-hmm. Any other questions?
I had some stuff floating through my head about CO2 retainers, but I think that pH is telling me that it's acute, therefore that is not a CO2 retainer.
No, this is probably not a CO2 retainer.
Right, because it's acute, correct?
Yeah. Because if it was CO2 retainer, the bicarb wouldn't be normal.
Yeah, the pH. would be
And the pH wouldn't be. All right, any questions? We're moving on. Now I got to go through chronic respiratory failure. See, I want you to know this so when we start pathophysiology, I don't have to explain this. We can just focus on the disease and like, oh, that makes sense. That's why they would have this kind of blood gas. Okay, I'll leave that up there just to show the difference. And I'm going to put it a little higher. Now, this pH is 7.35. This pH is 2. I'll still leave it 69 just for the purpose of teaching. 2, I'll leave that 53, I'll leave it 55, bicarb. 32, base excess, plus 4, and I'll put my static down here. I'll put that, make it 91%. This is a CO2 retainer. I see my pH is normal. This is acid. That's decreased. This is base. This is base. And this is slightly decreased. Okay. And I'll go back. This is on the wrong side. Everybody have it written down? Okay. So I see compensated respiratory acidosis with hypoxemia. Am I correct?
Yes.
All right. I see chronic respiratory acidosis with hypoxemia. Am I correct?
Yes.
Okay. Now, look, let's go back to the 50-60 rule. Look at it. 50 represents what?
PaCO2?
greater than 50. Is that PCO2 greater than 50?
Yes.
Okay. And my O2 of 60 represents what? PaO2 of 60 or less, right? Do I have that?
Yes.
All right. This is chronic
Yes.
respiratory failure. And what kind of patient will you see like this? CO2 retainers.
I get it now.
But we're not Johnny be good and to the rescue and give them 100% oxygen because we'll knock out their hypoxic drive. So we'll give them a nasal cannula 1 to 2 liters per minute. And if we can get this PO2 maybe raised to 63 to 65 torr, we're doing something great. Because they don't have they don't have central chemoreceptors to breathe off of. All they have is this. And we can't give them too much oxygen. So we do good to get them there. And they're still in chronic respiratory failure. Yes.
Is that usually all you'll be able to get them to when they're CO2?
Depending on their baseline, some of them may be at a 67, 68, but you'll never see a CO2 retainer at 70 torr, never. Because they're breathing off their peripheral chemoreceptors. So anywhere between 61, 65 is good. Any questions?
So,
See why I did it step by step by step, and I just want you to take it by steps. Therapists understand this. We understand as soon as we see it. We know what's going on. Yes.
You said that is chronic respiratory failure.
Chronic respiratory failure, chronic ventilatory failure with hypoxemia, compensated respiratory acidosis, whatever you want to call it. You just make sure it's chronic.
Compensated respiratory acidosis with
Hypoxemia.
hypoxemia.
Can't can't give them too much oxygen because we'll knock out their hypoxic drive. And when we do that, we call that oxygen-induced hypoventilation. So let's say if we get this PO2 to start going in the 70s, this will go up higher. That's why it's called oxygen-induced hypoventilation. The higher we raise the PO2, the higher this will go. So let's say if we got the PO2 to 70, we would probably shoot this 69 up to a 75. And they're worse because they don't have central chemoreceptors to regulate ventilation. Make sense? Okay, and if you give it, you're going to see it, yes.
So say you're working with a therapist, or you may be on the floor with a therapist, and the therapist doesn't know what she's doing or he's doing, and they give the patient too much oxygen to get that patient at 70. Does their condition decrease rapidly, or it's just a rapid decrease?
Yeah, it happened back in the summer. No, it was during the summer, but a student was employed, and what happened? He came and asked me a question. A therapist overnight, he didn't know the patient was a CO2 retainer, and put the CO2 retainer on a non-rebreathing mask. And when he got to the patient to do rounds, he noticed that the patient was lethargic. And he spoke to the nurse and doctor or whatever, and they got a blood gas, and the patient's PCO2 was 89. He had to be intubated. Now, I don't know what happened to the therapist, but I told the student, you did the right thing. He said, Ms. Miller, I got it. I saw it. You know, not good at a patient's expense, certainly not. But he saw it. He saw what I was writing on the board. It happens. And you don't want to be incompetent. God, you don't want to be incompetent. Because you can kill patients. Just with oxygen. Can you believe it? It can happen because it's a drug. All right, any questions? And we understand this. That's why I'm saying blood gases you have to work at every day. You have to work it every day. And I have more. It's more to come. I just want you to get to, I want you to understand the synonymous term ventilatory failure. Is it acute or is it chronic ventilatory failure? And then respiratory failure. I had some students that couldn't get it, so I had to be creative, and I made up that 50-60 rule. That's just a rule I made. And if you follow it, you got it. Okay. But what determines the difference between this and this is that pH. That's acute respiratory failure. This is chronic respiratory failure. The only kind of patients that you'll see in chronic respiratory, well, I don't want to lie, but for now, because there are some other type of patients, the only type of patients that you'll see are CO2 retainers. And so you can look at it one way. You can call them CO2 retainers, or you can call them chronically hypoxemic patients, because all they have are their peripheral chemoreceptors to breathe off of. You can look at it two ways. There is chronic hypoventilation, and there is chronic hypoxemia. Somebody say, well, why are they chronically hypoxemic? You chime in on the peripheral chemoreceptors, yes.
Is there any other disease that would cause somebody to be...
Absolutely. Histoplasmosis, pneumoconic, they're restrictive diseases, but for right now, I just want you to know this. Oh yeah, there are some restrictive diseases, yeah. Pulmonary interstitial fibrosis, absolutely. Yeah. But right now, just CO2 retainers, and you learn CO2 retainers are chronically hypoventilate, and they're chronically hypoxemic because all they have are their peripheral chemoreceptors to breathe off of. And so that's how you would see this blood gas. Any questions? Okay, one more for you. Now we're going on the alkalotic side. Okay. pH 7.49. PA CO2. Oh, I'll make it 20 days. Okay, go line by line and interpret that blood gas. I'm not writing the values, but this is PCO2, this is PO2, bicarb, A6, and 7. Write them down. And you should always have your little cheat sheet right in front of you. Not on exam, but I mean, this. Have your blood gas arrows or whatever you use right in front of you. Until you know it's just like a baby with a pacifier. You know when babies don't need pacifiers anymore because they'll take it out and give it to you or take it out and throw it out. Or turn their head. And after a while you won't need your cheat sheet, but not use it. Okay, so everybody have an interpretation for first blood gas? What is it? Uncompensated respiratory alkalosis. Okay. Acute respiratory alkalosis, right? Acute hyperventilation. Increased minute ventilation. Any of those terms you want to call it, right? All right. Everybody understand that one?
Yes.
All right. Because oxygenation status is normal. All right. Now, let's look at the second one. What is the second one? Uncompensated respiratory alkalosis with hypoxemia. See the difference? All right. So when you have acute hyperventilation with hypoxemia, uncompensated respiratory alkalosis with hypoxemia, whatever you want to call it, the difference between this blood gas and that blood gas is simply the PO2, right? When you have this condition, respiratory insufficiency. Respiratory insufficiency. So what's the difference? Respiratory insufficiency, the patient is hyperventilating and hypoxic. Respiratory failure, the patient is hypoventilating and hypoxic. We're getting there. This is probably an asthmatic patient. They're experiencing bronchoconstrictions, and they're having a difficult time exhaling, so we'll probably see their blood gases like this. Nothing's wrong metabolically. Kidneys are fine. It's too soon. They're struggling. This is called respiratory insufficiency. So when I use the term respiratory insufficiency, which of the following blood gases demonstrates or exemplifies respiratory insufficiency, you should know it. If I ask you to give me a blood gas demonstrating respiratory insufficiency, there it is.
And that's the PaO2.
Yeah, the difference between this blood gas and this is uncompensated respiratory alkalosis, but this is uncompensated respiratory alkalosis with hypoxemia. And another term that is used for this is respiratory insufficiency.
Okay.
Pulmonologists will diagnose respiratory insufficiency. What is that? Blood gases. Therapists will know. Yes.
So, asthmatics have a hard time blowing off CO2.
No, asthmatics are experiencing
But I
bronchoconstrictions.
thought they had a hard time exhaling.
They do.
Okay, so if they have a hard time exhaling, would they be retaining more CO2?
No, not necessarily. They're not CO2 retainers. They're still breathing off their central chemoreceptors. It's only CO2 retainers that don't have central chemoreceptors. Asthmatics still have their central chemoreceptors. And the central chemoreceptors will tell the lungs to work harder and blow it off, and they will.
So they're hyper.
They hyperventilate. Yes. Good question. But asthmatics have central chemoreceptors.
Okay.
Yeah. Yes.
So when we're looking at the PaO2, it's going to be 61 and above, normal, they're working on their central chemoreceptors. Anything 60, 59, 58, that's the peripheral. Correct.
Yeah, so if to make her question more valid, there you go. They're still breathing off their central chemoreceptors. They're still hypoxemic, but they're still breathing off their central chemoreceptors. And the central chemoreceptors are sending messages to the lungs, blow off this CO2. But that's not the problem. It's the central chemoreceptors responding, but we know the problem is bronchoconstrictions, right?
Yeah.
That's the problem. But we have all these little compensatory mechanisms in our body that respond. Okay, you see the difference between respiratory insufficiency and respiratory failure. And by the way, there is no chronic respiratory insufficiency. It does not exist. There is no patient that chronically hyperventilates. No way. So you know respiratory insufficiency is always an acute stage. It's always an uncompensated blood gas. Does that make sense to you?
Yes.
Okay. We have compensated respiratory failure because of CO2 retainers, but we never have this compensated or chronic. Never. This is always an acute stage. And actually, to compare, this is better. I'd rather have a patient in this state. Let's say if this is the asthmatic, cool beans. Because I can give them oxygen, take care of this, and I can give them a beta-2 agonist to take care of the wheezing. And once we address the wheezing, the respiratory rate or the hyperventilation will slow down. So this is easier to normalize than that respiratory acidosis. Retaining CO2. That's what people do. Yeah. What happens is when you're hyperventilating, or some people just have an increased respiratory rate. But if an individual does have an increased respiratory rate, what they do, they put the paper bag over their head so they can rebreathe some of their own CO2 to raise it. Make sense?
Yes.
That's exactly what they're doing. And that's what a partial rebreather does. When you put a patient on a partial rebreathing, they're rebreathing some CO2. So what's an indication for a partial rebreather? Respiratory alkalosis. Make sense? Okay. You guys are learning. You're getting there.
My light's going.
Any questions? On that green sheet, I believe third and fourth page or whatever. It has to be the third or fourth page.
On the way.
Is it?
The
Yeah, on the
examples.
fourth page, you have the question self-assessment. You can start doing it. You can't do all of it, but it's some self-assessment questions. So let's go back to page 3. Under respiratory acid-base imbalances. Let's look at number 2 now. Respiratory acidosis with hypoxia. I have hypoxia. It doesn't matter whether you say hypoxia or hypoxemia. I just used hypoxia. Okay. What you have is an increased PCO2, the decreased pH, and a decreased PaO2 level. Okay? And there I have also called respiratory failure, ventilatory failure with hypoxemia, hypercapnia with hypoxemia, hypercarbia with hypoxemia. That's your 50-60 rule. See it now? That's why I did what I did on the board and then went back to number 2. Any questions? And I know you have to absorb this. I know you got to take it away and absorb it, but I want to make sure what I'm saying, is there any clarity? Do you need clarity? Yes.
Can we still ask questions on Monday or Tuesday?
Absolutely. We by no way are we done with blood gases. Absolutely. You better. Yes.
It's going to take a bit to digest this.
I know it is. I know it is. And you all wanted more, wanted more. Here it is. Bam!
No, that was something else entirely.
Sure. Okay, let's look at number 4. Respiratory alkalosis with hypoxia. Again, hypoxia, hypoxemia. You got a decreased PCO2, increased pH, and now decreased PO2 level. It's also called alveolar hyperventilation with hypoxemia, hypocapnia or hypocarbia with hypoxemia, respiratory alkalosis with hypoxemia, or also known as respiratory insufficiency. Okay? So now we've gone 1, 2, 3, 4. We've gone through respiratory. I still got to get through metabolic, but I'm going to stop because I know you have to study and absorb. You have to study blood gases every day. And I'm holding you accountable. But I'm giving you increments. I encourage you. I'll tell you from the day from now until you graduate, you're champions. But Kathy Miller holds you accountable. And don't tell me you can't do it, because you can. And I know it's a lot, but it's going to make a whole lot more sense to you once we get into the diseases. You'll be like, oh, okay, well that makes sense. Oh, okay. And then especially when you go to clinical, and unfortunately, some of this stuff you'll see. All right, any questions on anything we've covered today? Okay. Put your sheets away. Spread eagle.
Can we just scan for this?